Welcome to the Surgical Edge podcast for surgical insights, reviews, discussions, and to stay updated. Let's dive in.
Welcome to the Deep Dive, your shortcut to being well-informed. Today, we're tackling something really critical, a challenge that comes up a lot for clinicians, particularly in surgery and acute medicine. We're talking about managing blood glucose, especially around operations or when patients get really sick. And specifically, we're zeroing in on variable rate intravenous insulin infusion, or VRII. You might have heard it called a sliding scale, maybe less accurately. We'll definitely get into why that term isn't quite right. Our mission today, it's really to pull out the essential stuff you need to know. We want you to understand when to think about VRII, how to manage it safely, and crucially, the why behind it all. It's about getting that deeper understanding.
Exactly. And, VRII, it's powerful. It's definitely what we consider a high-risk therapy because of that power and how quickly it acts. But when you use it correctly in the right situations, it's absolutely vital for getting good glycaemic control in patients who are, metabolically quite fragile at that moment. Improving that understanding is key for safety.
Okay, and before we really dive in, we have to put up that important flag. The information we're discussing here today, it's for reference, for discussion, to help build understanding. It is absolutely essential, non-negotiable really, that all practitioners stick to their own standard local guidelines and their hospital or institutional policies when actually treating patients. Think of this deep dive as adding to your knowledge base, not replacing those crucial local protocols. They always come first.
Couldn't agree more. Those local guidelines are paramount.
Right. So with that clear, let's map out where we're going. We'll break down the key times you'd initiate VRII, explore those really important safety checks, and understand the core principles driving its use. Let's get started. Okay, first things first. Let's clarify what VRII actually is. I mentioned that term sliding scale pops up a lot. Why is that not really the best way to think about VRII?
Yeah, that's a really important distinction to make right off the bat. Sliding scale. It often suggests this kind of reactive approach, doesn't it? Like, you see a high blood sugar reading, you look at a chart, give a fixed dose of insulin, usually subcutaneous. The problem is that often leads to this up and down, this sort of roller coaster of glucose levels. High sugar, insulin reaction, then maybe low sugar, that bounces back high again. It's often chasing the numbers after they've gone wrong.
Okay, so reactive versus...
Exactly. VRI is fundamentally different. It's a continuous intravenous infusion. That means insulin is going in constantly, and we can adjust the rate very precisely, almost minute to minute if needed. And because it's IV, it acts really fast, and its effect stops quickly when you turn it down or off. That's why we call it high risk. It needs super careful management. It's reserved for situations where the patient's usual routine, like subcutaneous injections, just isn't going to cut it, or might even be dangerous because things are changing so fast metabolically. So the core idea, and this is vital, is that VRII is usually a planned, proactive strategy. We're often starting it to prevent the big glucose swings we anticipate are coming, or to stabilize things when they're already volatile. It's not just reacting to a single high reading. That proactive thinking is key for safety.
That proactive versus reactive distinction is, that's really helpful framing. So if it's this planned, powerful tool, what are the specific clinical scenarios? When should clinicians be thinking, okay, maybe VRII is needed here?
Right, that's the million-dollar question, isn't it? We can kind of group the main indications into three broad categories. Each has its own triggers and reasons. The first one, and probably the most commonplace many doctors will encounter it, especially in surgery, is for perioperative management of patients with diabetes.
Okay, so around the time of surgery.
Precisely. And what's interesting here is often this isn't an emergency thing. It's part of a planned pathway, especially for elective scheduled surgeries. Think of it like getting ahead of the metabolic stress that surgery inevitably causes.
So when would you typically start it in that scenario?
Usually, preoperatively, often on the morning of the surgery itself. And the timing's really important. You start it before they're made nil by mouth, or NBM, and definitely before anesthesia is induced. Why so early? Because you want to get their blood glucose stable before that big physiological stress hits. Surgery unleashes hormones like cortisol, adrenaline, things that naturally push blood sugar up. Starting the VRII beforehand lets you counteract that right from the get-go.
And who specifically are we talking about here? All diabetic patients having surgery?
Good question. It's mainly for patients with type 1 diabetes. They absolutely need insulin continuously. And also for patients with type 2 diabetes who are already on insulin. That could be someone on a basal bolus plan, with long-acting and mealtime insulin, or maybe someone on mixed insulin. If they're having surgery, especially major surgery, or even minor surgery that requires them to fast for a significant period, their normal injection routine just isn't safe or practical.
Why?
Well, their usual doses are based on eating regular meals and normal absorption from under the skin. When they're fasting, giving those usual doses could easily cause severe hypoglycemia. Plus, the stress of surgery itself makes their insulin needs unpredictable. So the VRI's goal here is really twofold. One, prevent significant hyperglycemia, high sugar, which we know can worsen outcomes like increasing infection risk or slowing healing. And two, maybe even more critically, prevent dangerous hypoglycemia, low sugar, especially when the patient is under anesthesia or recovering and can't tell you they feel unwell. It's about keeping them in a safe zone.
That makes a lot of sense. You need something highly adaptable when everything else is changing. Okay, so that's the planned perioperative use. What about when things go unexpectedly wrong for a patient already in the hospital?
Right, that's our second major category, management of acutely ill medical and surgical inpatients. So this is for patients who are already admitted, maybe for something else entirely, and then they become acutely unwell. Their diabetes management, which might have been fine before, suddenly isn't enough.
Okay, so what triggers the thought of VRII then?
You'd consider it if the patient has persistent hyperglycemia. We're talking levels consistently, say, above 12 millirel, even though you've tried to optimize their usual subcutaneous insulin. It's not working well enough. And this is important. They also need to have one or more other acute issues going on. For example, maybe they are nil by mouth. Perhaps they have an ileus after surgery where their gut isn't working, or they're waiting for an urgent operation. Or they could have serious coexisting problems like sepsis, or they're in shock, or needing drugs like inotropes to support their blood pressure. Patients in critical care, like HDU or ICU, often fall into this category too because of the sheer metabolic stress they're under.
So it's the combination of high sugars despite treatment plus a significant acute problem.
Exactly. Or even just being unable to reliably eat or drink enough to make subcutaneous insulin safe and predictable. And the key thing here is VRII isn't usually the first thing you jump to in these cases. It's an escalation. You typically start it once you see this picture emerging and after you've reviewed their current diabetes meds. Is their usual insulin being given correctly? Are they on new medications like steroids that are pushing the sugar up? You check those things first. But if conventional methods are failing because the patient is just too sick, then VRII becomes necessary.
Okay, so it's a step up in therapy when the clinical situation really demands that level of control and adaptability. Now, what about those real metabolic emergencies?
Yes, that brings us perfectly to the third category, and it's a bit different. Diabetic ketoacidosis, DKA,
Yeah.
and hyperosmolar hyperglycemic state, HHS.
Right, DKA and HHS, these are emergencies.
Absolutely. Life-threatening metabolic emergencies. And for these conditions, VRII isn't just an option. It's pretty much the standard first-line treatment for the insulin part of the management. In DKA and HHS, the body's metabolism is severely out of whack. In DKA, you have massive sugar levels, but also acid buildup from ketones. In HHS, you have extremely high sugar, leading to severe dehydration and thick, concentrated blood. Subcutaneous insulin just works too slowly and unpredictably to fix these situations quickly.
So you need that immediate controllable effect of IV insulin.
Precisely. VRII needs to be started immediately, right alongside aggressive 5E fluid resuscitation and careful electrolyte replacement, especially potassium. It's a critical part of stabilizing the patient. The insulin infusion rate is started, often based on weight, like 0.1 units per kilogram per hour, and then adjusted based on the response. The aim is to bring the glucose down gradually, resolve the acidosis in DKA, correct the dehydration and hyperosmolarity in HHS, but not too fast, because dropping the sugar too quickly can cause its own problems, like cerebral edema. It's a carefully managed process where IV insulin is absolutely essential.
Okay, so that really clarifies the when. Perioperative planning, acute illness escalation, and then those immediate DKA-HHS emergencies. Now let's pivot. We know when to start it, but what about keeping it safe? This feels like where things could potentially go wrong if not managed meticulously. What are those crucial safety aspects?
You're spot on. Safety is paramount. Because it's so potent, the potential for harm, particularly causing hypoglycemia, is significant if you're not careful. There are some non-negotiable rules. First, and this is a big one, VRII should never be used just on its own to fix a high blood sugar reading in a patient who is otherwise stable, eating and drinking normally.
So if someone's just hyperglycemic but everything else is okay?
Exactly. If they're stable and eating, the right thing to do is look at their usual diabetes treatment, their pills, their subcutaneous insulin, and adjust that. Using VRII as a quick fix in that situation is inappropriate. It introduces all the risks of IV insulin without the actual need, and it can make things more complicated later when you try to switch back. It's tempting, maybe, but it's not what VRII is designed for.
Right, using the right tool for the right job. What's next on the safety list?
Second, and absolutely critical, the simultaneous dextrose infusion. In almost all cases, when a patient is on a VRII, they must also have a separate 5e infusion running that contains glucose, usually 10% dextrose, often with added potassium. Typically, this runs at a steady rate, like maybe 100 milliliters per hour.
Why is that so vital?
Well, the IV insulin is working hard to lower blood sugar. If the patient is fasting or very unwell, they might not have enough glucose coming in from food or being produced by their own body to counteract that. Without that separate dextrose infusion providing a constant background supply of sugar, the insulin can easily overwhelm the system and cause severe, dangerous hypoglycaemia. It's basically providing the fuel while the insulin helps the body use it, preventing the blood sugar from crashing. And the potassium. Insulin pushes potassium from the blood into cells, so you need to replace it intravenously to stop blood potassium levels from dropping too low, which can cause heart rhythm problems. Forgetting the dextrose and potassium is a classic and potentially very dangerous mistake.
That detail about the dextrose and potassium really underscores the complexity here. Okay, what else is crucial once the infusion is actually up and running?
That leads right into the third point, rigorous monitoring. You absolutely must have frequent blood glucose monitoring. We're talking capillary blood glucose checks, usually finger pricks. How frequent? At least hourly when you first start the VRII, during surgery, or any time the patient is unstable. Once things settle down and their glucose is more stable, you might be able to stretch it to 2 hourly, but certainly no less frequent than that while the VRI is running.
Hourly to start, maybe 2 hourly later. That sounds intensive.
It is intensive, and it has to be. Without that frequent data, you're essentially flying blind. You can't possibly know if you need to increase the insulin rate, decrease it, or keep it the same. You need to see the trend, not just single numbers, to adjust safely and effectively. It's the only way to avoid both hypo and persistent hyperglycemia.
Makes sense. You need the data to make adjustments. And the last safety pillar.
The fourth one is about process, formal prescription and protocol adherence. VRII has to be prescribed properly using a specific standardized VRII prescription chart or electronic equivalent, and it must follow your local approved hospital protocol.
So no scribbling orders on a regular drug chart?
Definitely not. Using a dedicated chart ensures all the necessary bits are included. The insulin type, the starting rate, the target glucose range, the titration instructions, the linked dextrose potassium infusion, the monitoring frequency. It standardizes everything. And sticking to the local protocol means everyone involved, doctors, nurses, pharmacists, is working from the same playbook, using evidence-based guidelines. It reduces errors and ensures consistency. This isn't just red tape, it's a crucial safety mechanism for managing a high-risk therapy. Any deviation needs careful thought, senior input, and clear documentation.
Okay, so putting it all together for the clinicians listening, what's the takeaway? VRII is clearly a very potent tool, but it sounds like it demands this really structured, proactive management style, intense monitoring, that essential dextrose infusion. It's definitely not set and forget.
Not at all. That's the perfect way to put it. It's high reward in the right situation. It can give you excellent glycemic control when nothing else will, but it absolutely requires that precision, that vigilance, that adherence to protocol to manage the risks, especially the risk of causing hypoglycemia.
Right. So connecting this to the bigger picture, the message seems to be VRII is vital, sometimes life-saving, but its use is always embedded within a strict protocol. The focus has to be on planning, constant assessment, and those safety nets like monitoring and the dextrose infusion. It's about using this powerful tool responsibly.
Precisely. It's about harnessing its power safely.
So this deep dive, we hope, has really illuminated when VRII is the right choice, from that planned perioperative setting to acute illness and emergencies like DKA-HHS, and hammered home those non-negotiable safety steps. And just to reiterate that crucial point, use this information to deepen your understanding, but always, always follow your specific local guidelines and hospital policies in practice. They are designed for your environment. And to leave you with something to think about. As our patient populations get older, more complex, with more diabetes and other conditions mixed together, what's next? What kind of innovations or maybe refinements might we see in managing blood sugar in surgical or acutely ill patients? Are there things beyond VRII protocols, maybe new technologies or drugs that could change how we approach this in the future, something to mull over?
Thank you for listening to the Surgical Edge podcast. Don't forget to like, share, and subscribe. Help us grow and deliver even more relevant surgical content by pressing the support button. Your contribution truly makes a difference. And don't forget to share with us your advice, feedback, and the topics you would like us to include.